Evening and thank you everyone. Welcome to today's English session. Today is our 1752nd day of continuous webinar. For conducting this kind of uninterrupted webinar, many efforts are needed. Thank you all for working to this IFPH webinar. Thank you so much. And now I'm introducing today's our speaker is Dr. YAMINI VASHISHTH. She's homeopathic. She studied homeopathy from Baxton College of Homeopathy, and she had done her MD from Dawale Memorial Homeopathy College, Palghar, Maharashtra, and she's now working in Basel Homeopathy. And today's our subject is Journey Towards Unprejudiced Observer. That is a very interesting subject. I am welcoming Dr. Yamini to our webinar. You are welcome. Please.
Thank you, doctor. Thank you. I think I'm audible.
Yeah, you are audible. And you are the co-host. If you want to share, you can share also.
Okay. Yes. I hope my screen is visible.
Yeah, started. Journey Towards Unprejudiced Observer. Yeah, visible.
Hello, good evening, everyone present here. We are going to take this topic, a journey towards an unprejudiced observer. Since our first year of BHMS, we keep hearing this, the unprejudiced observer, and the aphorism 6 always haunts us, kind of, that how to become an unprejudiced observer. So let's begin. So we all have taken many cases, and we know what is the performa of taking case history. So we take the preliminary details, then we comes to presenting complaints, the history of presenting complaints, then the past history, the family history, the habits the patient has, obs gynae history in cases of female, physical generals, then the mentals or the life space. Every doctor has their own unique way to collect the mentals. So then we do the physical examination. And we have learned the significance or the need of all these headings in case taking. So why do we take preliminary details? So we are not going to go in details in that. We all know why the significance of all of these, and how these all headings helps us to understand the patient. Okay, so we know the guidelines given in the Organ of Medicine by Dr. Henneman. So in aphorism 83, Dr. Henneman.
Yamini.
Yes, doctor.
Your face is not.
Yeah, I just
not yeah, adjust it. Otherwise, it won't be. Okay. Thank you.
Okay. So Dr. Henneman asks us to be free from prejudice and have sound senses and pay attention in observing. Okay, in aphorism 89, Dr. Henneman asks us to be more precise and ask more special questions in cases where the questions are needed. In aphorism 94, Dr. Henneman tells us that in chronic diseases, it is important to ask the patient regarding his ordinary occupation, his usual mode of living and diet, his domestic situation. So, and he has given the reason also that why do we need to understand the mode of living or the domestic situation of the patient. Today, I am going to share what I have learned during my MD, different techniques of case taking, which are used in interview. So these can be medical interviews, and it can also be any kind of interviews. We see there was a movie, I forgot the name, the web series recently which was released. There was a child who had committed the murder and the aftermaths of it. So it was very interesting to see the psychological interview which is given in the show. I'll just remember the name and let you all know. And it is very interesting that the different techniques the psychologist uses to get the to understand the little child. He was 13 or 14-year-old and he had committed a murder. So to understand the psychology of that child, so we need to understand the techniques. We all use it also in our case taking, but we are not very well aware of it. So if we are aware of these techniques, we can know when and where to use these techniques to become a better physician and take a precise case history. So the first is questioning. It is very common and it is very straightforward. You ask the question and the patient is going to answer it straightforward. It saves time and very specific information is obtained. But since it is very formal, it does not lead to establishment of a satisfactory relationship. And it is done either when the patient is not cooperative, when they are not willing to open up to us, and sometimes it happened during our first sitting that with the patient is not very comfortable to share the personal spheres of his life. So we can just start with normal formal questioning. And when in cases we know that the entire case and we just have to make a final choice, so we can sort to questioning. It is very useful in taking the presenting complaints because it is all data we require. There is nothing else. We just need to be very accurate and specific regarding the questions, where it hurt, how is the pain. So it is very formal and exact specific we need in taking the presenting complaints. Then comes exploring. It is an open-ended inquiry. So we are not going to ask specific questions. Even in organon of medicine, Dr. Henneman ask us to avoid leading questions when they are not required. So if we are taking the life space of the patient, or we are trying to understand the mentals, so we do not ask direct questions. We do not ask leading questions. We ask open-ended queries so that the patient can explain in detail regarding his experience. So it is very advantageous but also hazardous. So patient can go on giving us the irrelevant details which are useless in our case, or the patient can give very important details regarding his experiences. So either way, we'll understand later that if the patient is being irrelevant, then in those cases, what we need to do. Then comes listening. Obviously, this is very much required and recommended also, as it encourages the patient to talk and share their experiences. And listening should not be confused with passivity, that whatever patient is going to speak, we are going to listen. It is not that, but what we say perceiving, like what Dr. Hinman has talked about perceiving, that we are not just listening, we are also observing. Then comes that happens simultaneously. Okay, that is a concomitant that happens with listening. Fourth one is observation. Okay, so we are listening and we are also observing the patient's non-verbal gestures, which are vital clues when the patient is breaking the eye contact, when the patient is being little low or thinking about something, like he has remembered some experience from the past. So we listen and we observe. Then comes blocking. This is very useful technique when the patient is not keeping to the point. So when we give an open-ended question to the patient in exploration, when we need to explore, there comes a point when we need to block the patient, but it should be in such a manner that it should not offend the patient. And also before blocking, we need to give some concession, because sometimes it may happen that the patient will come to the point, but before blocking, we need to see whether the patient is leading us to something useful or something irrelevant. Then comes guiding. This is similar to blocking, but in a different manner, because it is an obtrusive method of taking the patient where he is not aware of. So sometimes it happens that we understand the patient where the problem lies, but the patient may not be aware of it. So in a very gentle and indirect manner, we need to bring the patient to that area. Like for example, we had a teenage patient, female patient, whose mother was already our patient. Okay, so through the understanding of that mother, we knew that she was little controlling and a conservative kind of a lady. So when the daughter comes to us, we already know what could be the problem, cause of the problem of her PCOS. She came to us for her PCOS. So we don't have to make it very direct to the patient that your mother is being controlling or your mother is conservative, but we need to understand what goes through, what the patient is going through that controlling environment. So that is guiding. And we need to be very aware of the area. So if we are not aware, it will be equal to exploring. If we do not know what we are leading the patient to, then it is equal to exploring. Then come assurance. In course of interview, the patient may get disturbed or confused, and because patients are not very used to uh, exchanging the experiences. Okay, so allopaths do not ask how did you feel when your mother died. Okay, so it is us. So when they share some experience with us, so they may get confused whether this information was relevant or not. So at these points, we need to reassure the patient that the patient is being accepted and he may continue to share his experience. Then come confrontation. It is like a double-ended sword. So confrontation is needed when patient is avoiding the acceptance of the truth. Okay, certain amount of honesty and choice of right timing is very necessary, as confrontation may lead the strain of relationship. So it can spoil a doctor-patient relationship if it is done at the wrong place. So we had a patient, uh, I think the patient was in his 40s, male patient, who came us with early onset of Parkinsonism. And through the case history and chronology, we understood that the patient had an extramarital affair. And due to that a dilemma of being guilty and having the desire to live his life at his own ways, that nervous system of the patient was failing and was leading to Parkinsonism. Okay, so we had to confront the patient that this is the problem of everything else. Okay, so the cause of the problem was that, and the patient needed confrontation. So it should be done at the right point when the patient is able to receive it in that manner. Okay, then comes counseling. So sometimes the cause of problem is not very deep. Okay, like the previous one. Sometimes it is very superficial. For example, a patient comes to us and says that I have problem managing my time. I cannot have time for self-care or self-reflection. I cannot have time for exercising. And when we take the entire daily routine, we ask them and they say that they spend around 7 to 8 hours just scrolling their phone. So it is kind of a superficial problem. So in those cases, we need uh, okay. So we need counseling, and when it is not comprehensively planned, the difficulty may persist. So you just cannot say that stop using your phone and go exercise. So it has to be more comprehensively planned so that the patient is able to follow it, and that's what counseling does to remove the superficial maintaining cause of the diseases. Then comes silence. Silence is a very powerful device and it is used in these three situations. First is when the patient himself needs it after he has ventilated. So the patient needs time to come back from the past and be in the present. So they need that silence. Okay. Then when the patient has come to the end of narration. Okay. So he has done whatever he has to say, and then there is silence. There need to be silence. Then when the physician expects the patient to cooperate, but there is resistance from the patient. So here it becomes very powerful that the patient needs to know that he is not going according to us. He is not helping us in any manner. So we need to be very silent and composed and show the patient that he needs to be more cooperative. Mhm. Okay. Then comes informing. It is a technique when we see that when there is a lack of information, which is the major cause of the problem. Okay, so for example, we had a female patient who had cervicitis, and when we were taking the sexual history, she told us that her husband has balanitis, and they do not even remember since how long or who got that infection first. So they were the infection was just going to and fro from both husband and wife, and because they were not aware that this is leading to their problem, so they were asked to stop having intercourse for, until unless both of them get treated for their STD. Okay, so in these kind of situations, we need to inform the patient. Then come interpreting. It is a skill which is developed over considerable experience under supervision. Okay, so interpreting is actually deriving meaning which adequately explains the phenomena seen in or by the patient. So patient gives us something and we need to interpret something else from it. Okay, to understand the core of the patient, because we cannot take everything at the face value, whatever patient says us. So, but the difficulty in interpreting is that our subjectivity as a patient comes in between and is likely to interfere. So when we are interpreting, we need a supervisor, okay, be it our seniors or our teachers, who can tell us that, okay, this interpretation is right, this interpretation is wrong. So it is developed over a period of time. Then comes refusing. Okay, sometimes patient has various requests which are not necessary therapeutically. So we need to refuse the patient. Many a times patient comes and they ask us for minor trivial ailments. They may ask us to write a list of investigations. So we need to refuse it. Okay, and the manner should be very educative and reforming. It should not be rude, or the patient should not feel rejected. They should understand that these tests are not going to get any useful information, and we already know, or the complaints cannot be seen in the investigation. So we need to refuse certain requests of the patient when required. Then comes empathizing. Empathizing is very important, and it depends on sensitivity with which the physician is receiving the patient. So it empathizing can have two outcomes. So the first one is when we are unable to empathize with the patient, when we are actually are not able to relate to the patient's problem. So we may try to empathize because it is necessary, but the fakeness of that empathy can be visible to the patient. So for example, if a unmarried patient is taking a case of a married woman who has not who doesn't have children after 2 3 years of her marriage, and the physician thinks that it is not necessary to have kids because she is not in that age group where, and she is not yet that evolved mentally. So even if they try to empathize, it may show that it is not existing, it is fake. So that is one outcome. And the second outcome is, if the patient is very sensitive to the situation, they may identify with the patient, and they the world of the patient becomes of their own. If the physician is herself married and not having kids, so she may become very sensitive to the situation of the patient, and she may lose the balance, and instead of empathizing, she may start sympathizing with the patient. So these are the two outcomes. So we need to strike a balance where we need to empathize with the patient. Okay, so 15th one is not accepting. So patient in the interview, we see their world. Okay, so they give us a glimpse of their world, but the physician need not accept it. Okay, so like confrontation, even this needs right timing. We need to tell them that whatever you are saying is not acceptable, but in a very calm manner, that the patient should not feel rejected or alienated. So at the point of interview, when the patient is able to realize that it is not the entire patient which is being rejected, but only a certain situation or certain part of him which is being rejected. So it is very commonly, it is very common that humans tend to self-victimize. Okay. So be it a mother-in-law or a daughter-in-law, both of them will think that we are the victims. So we need to understand them, we need to listen to them, empathize with them, and after a point we need to show them that whatever they are thinking is not exactly right. It is not the totality. Okay, it is not that you are not the victim. We need to show them that it is what both the parties need to change. So this is what non-accepting is required and is also little tricky. Then comes last one is role playing. Role playing makes it possible to instruct the patient through a live demonstration of what he has not been able to accept or adapt to. So, if just like the previous example, mother-in-law and sister, daughter-in-law. So, physician can role play with the patient and assign the role that, okay, now you be the mother-in-law and I'll be you. So, these kind of role play can only happen when we have accurate understanding of patient's world. Okay, so we know like how can her mother-in-law react to this kind of situation, or she may react to this situation. Only then we can have this role play to make them understand how the dynamics goes on. Okay, so these are the interview techniques. Now I am going to demonstrate a case which I had taken, and there is going to be a little interactive activity after the demonstration of case. It is not the remedy. I'm not going to ask all of you the remedy, but I just want you to pay attention to the data which was collected and how it is being presented. Okay, just look at the data, and after that there will be a small activity, and I would really like if every one of you will interact. Okay, so the case demonstration. Okay, so this is a case of a 48-year-old female whose education is MA and B.Ed. Her occupation is currently homemaker, and she is being married since 13 years and not having any children of her own. Her presenting complaints were as follows. First one was pain in bilateral feet since 10 to 12 years, which started gradually, increased in 2020, and now it is moderate and continuous. It started from right and then happened to the bilateral feet. Currently, the right foot pains more than the left one, and there is pain in heel in the right foot. The pain is drawing kind, and it radiates from feet upwards till thighs. There was a constant heaviness and dullness in the entire legs, and the pain in right knees after walking, which occurred since 3-4 years. Aggravation was from walking, night, first step on the foot, and amelioration was from rest. She took allopathic treatment for this, and which gave temporary relief. And when the treatment was discontinued, the complaint resumed. She had headache which since the age of 22 to 23-year-old, and the frequency and intensity was as it is. There was no progression of this complaint, and the headache began from one spot from entire head. Either it can be supraorbital or frontal or parietal or occipital, and the pain spreads all over the entire head, then comes to the face, and then to the nape of neck. The headache was periodic. It usually happened 8 to 10 days, at a period of 8 to 10 days. And it feels as if the head will burst from within outward, and there is pressure from within outwards. So she had a gastric kind of headache also after eating chana or chole or rajma, these kind of lentils, and aggravation from lying down, walking, night, thinking about the complaint, stooping forward, and the pain which starts from a spot can also begin if she is lying down on a spot for a longer period, and the pain start from that point of pressure, and it radiates to entire head. Then she had itching all over her body since 1.5 years, started suddenly after allopathic medicine for leg pain. There was pricking sensation, and the touch of clothes was unbearable. Itching can start anywhere, anytime. So there was no any specific modalities. Aggravation, time modalities. Aggravation from clothing, lying on bed, warmth of a bed, warmth of the body, which parts contact the bed. Because of the warmth of bed, she had that itching, and emulation from scratching. So there was a swelling of the ring finger in the right hand since 2-3 years on off, and there was a kind of stiffness or drawing pain while making a fist. There were a black color apthe inside the upper lip, and there were no complaint. There was no burning or pain. They just used to stay for 8 to 10 days, and they would disappear. Then there was pain in again. I went back. Okay, we were here, right? Yeah. Okay, so there was pain in bilateral shoulders and arms. And in this also, the right side was more painful than the left. The range of movement was full, but it was painful. So she was able to have the full range of movement of her shoulder, but there was pain while raising the arms above her head. So aggravation was from pressure on affected part and lifting weight. Then she has complained of heat flushes since 2 years. So it happens 1 to 2 days per week. It can happen anytime. And the sweating gives relief. And the sweating was that much that the feet would leave mark of sweat on the floor. So the entire body was generalized sweating, but the feet used to sweat even more. Okay, so the past history, she had a scorpion bite when she was in 8th standard, and a dog bite when she was 22 to 23 years of age. She had a root canal treatment of 2 premolars in 2024 March, and she had taken 3 doses of COVID vaccine. Menstrual history, menopause since 1 year after at 46 years of age, and menses when they used to occur, they were regular with mild to moderate dysmenorrhea, and the flow was normal. Ops history, she got pregnant 4 times. The gravida was 4, T0, live birth 0, and 4 abortions. So the first abortion happened at 3rd month of pregnancy when the patient was 36 years of age, and later 3 consequent abortions at 1st month. Okay, few days used to just delay. The menses used to delay for few days, and then she used to abort. So those 3 abortions, because her menses were very regular, so she knew if even one day it is delayed, that means she had conceived. So so she had total of 4 abortions. Family history, father had deafness, and at later stages of life, when he got very old, he got prostate cancer, and then died after 2-3 years of detection. Then mother had OA, and her BP shot to 400, the systolic one, and then she died in 2015. Okay, so sister also had a history of cancer, probably of pancreas. She was not very sure and was treated. And brother had hypertension. Physical generals, appetite was normal. Thirst was like she used to drink 2 to 3 liters of water per day. Desire of warm food, spicy food, and specifically jalebi. In sweets, she liked jalebi. Thermals, both the extremes were unbearable, and she had chill veins in winters. The toes would swell and they become red. And after giving warmth to the toes, the chill veins had embarration. Perspiration all over body, leaves bite sediments sometimes, and there was no offensive smell. Stool unsatisfactory 2 to 3 times per day. So the color was brown, consistency was normal, and she always had a constant urging, like the more stool will pass, but it wouldn't. So she had to go 2 3 times, and still the stool was unsatisfactory. She had no complaints in urine. Sleep was unrefreshing. Wakes up tired. Awake till 2 3 a.m. Restlessness followed by desire to cry. Too many thoughts of past, of things done wrong or said wrong. And she had dreams which she remembers sometimes. And the dreams of were of random daily stuff and about family or going on trips. And there were no recurrent dreams. So, life space, the patient was born in a joint family, and the family comprised of parents, one elder brother and one sister. And after some time, she was brought up in different city. So, since childhood, she was very obedient, and if denied anything, she never said it again. For example, there is example. Okay, I'll tell you. Buried any dreams in order to avoid any disagreements. She says, ki, I can give up on all my dreams or all my desire, but I cannot bear that there are any disagreements or fight due to my desire. So this was a very peculiar thing. And like she wanted to go out and with friends learn cycling or do BTC. This is a course, but since she was denied, she didn't do any of these. She was of a very mild and emotional, never fought with anyone whatsoever, had a very good friend whose mother broke their friendship. So after that, she had no attachment with anyone since then. uh, she had a late marriage because she was short in height and she had gap between her teeth, so she was not very beautiful. She had a late marriage, but she was not very perturbed by her looks. She had accepted her looks, and there was no pressure from the family also. Okay, this is family. Neither the patient was sad about it that I'm not getting married, so she had no uh, expectations from the future. She was okay with whatever was happening. So she had that if everyone wants beautiful bride, let them get. So I'm not bothered about that. So she had a compromised marriage at age of 35 years of age with an older man who was divorced and had 2 kids. So she felt sad initially, but she adjusted. Then she had to uh, travel to the village after marriage, and then her husband used to work at different city. So whenever her husband wasn't there in the village, she used to live with her brother or parents, okay, due to the inconveniences of the village, because she was not used to living in village. And whenever her husband used to come, she would go to the village. The husband was ill-tempered and scolded her for little things, never replied normally. And the patient never replied to her husband, and she just listened and cried, accepted her fate that, okay, this is what my fate is. So husband has 2 children who live with their grandparents, and she has congenial relationship with them, but not very close to them. Now, since few years, she had started talking back when she's not wrong, and husbands also started listening to her. She is able to express a little better to her husband, but she mostly tries to keep her feelings to herself. Feels bad when someone asks about her children, so she instantly she get that weeping disposition. Sometimes she cries also whenever someone asks, do you have children? Okay. So she regrets about first abortion. So the regret was that her husband was in different city and she was in different one. And she had a mild pain and bleeding spotting on one day. but she didn't go to the hospital, or actually she was alone and there was no transportation, there was transportation issue. So she called her some relative and this, that. So she got to the hospital one day later, and by that time she had aborted the fetus. So she feels bad about it, that it would have been better that if I was with my husband, or my husband was with me, or I could have gone to my parents' house, because she was alone that time. So she had that regret, and of not pursuing her husband for IVF. So once she told we'll do IVF, her husband said okay, and then he forgot or something happened, and then she never said it back that I want to go for IVF. So she had this regret, and there are no regrets for saying right things to anyone, and she feels bad if she ever has said anything wrong about someone or wrong to someone. So she tries to keep herself busy in the household stuff, and she likes learning new things. So sometimes she'll try tailoring, sometimes she'll learn typing on a computer. She learned at that age also, she was learning how to ride a scooty, or and even bike. She was very eager to learn how to ride a bike, and she would just keep learning new things to keep herself busy. And she had this is school. Now she has taught in the school for some time, and then she had to leave the job because of the long distance. So the observation was, first the patient cried 3 4 times while narrating the symptoms, even at some point which didn't even amount to crying. So okay, it was understood, okay, she didn't have children, so she would cry while narrating how she aborted, or how she feels when people ask her. But at times when the situation didn't amount to crying, she was of weeping disposition. Okay, so she couldn't remember the history of present of any presenting complaint instantly. So everything she was like, I don't remember this. Then she would take some time, remember it, and then she would say, okay, when I was at that age, then this happened. So she was she was little slow in comprehension and remembering things. Then a few times, the difficulty in understanding the questions. I had asked her something else and she was answering something else. So I had to like ask her the question again. No, I don't mean this. I meant that. So to get the answer, I had to do that. So these are the observation. Now, I would like everyone to answer this. What do you think the physician has missed, or what could have you done differently? So if you think that the physician, don't consider that I am the physician, because in this manner you won't be able to give any constructive criticism. Just see it as an case, and what do you think is missing in the case, or if you would have taken this case, what are the different areas or different ways you could have handled this case? Anyone? I would like you all to put something in the comment box. What different thing you would have done? Anything? How do I see the chat box? Okay, yeah, the chats. Anyone wants to add something to this case? In the case taking, I'm not talking about the remedy selection or anything else. Okay, so if no one is willing to, I will have to take this. I thought that Indians are very good at fault finding. I thought I would get many messages in the chat box telling me that I missed that, or they would have done or added something new to it. So I would myself evaluate as a third person. I would evaluate this case and see what was missing. self-evaluation of the interview. So first we'll see the adequacy of the interview. So the whatever skills were used, they were adequate enough to collect enough data to understand the patient as well as the disease and to prescribe a remedy. I think if not instantly, everyone can just repertorize or evaluate the symptoms and they can prescribe some or the other remedy to this patient. Okay, so it is at least that adequate. The data collected is adequate. Understanding the problem. First, understanding of disease and understanding of patient. So understanding of disease, what I had reached when I took the case was like the bilateral feet pain looked more like of neurological origin, which could be of vitamin B12 deficiency. The bilateral shoulder pain were probably due to tendinitis because there was pain, there was tenderness on pressing the on touching the shoulders. Headache was tension headache. Skin itching, I could not understand the cause behind it. There were no eruption and nothing, and no such modalities. Maybe could be a liver issue or raised serum phosphorus because that leads to itching. Heat flushes was because of menopause. So most of the complaints, they were either at functional level or they were reversible structural issues. Okay, and the prognosis of the disease and as one wholesome, if you take entity, it was the prognosis was good. Then understanding the patient. Okay, so the patient is of mild temperament. Here we can understand the skill of interpretation. We are trying to interpret whatever data we have collected from that. What kind of patient is this? So the patient is of mild temperament, sensitive, but does not express her feelings to anyone. She is a kind of a pacifist. She tries to avoid any disagreement or fight, even if she has to compromise. So she is self-dependent and willing to learn new things at any age, likes to test her limits and do new things even in conservative environment. Slow in comprehension and actions. Still, she was willing to, learn new things. Has a few regrets in life, but not acting in the right time, about not acting in the right time, which troubles patient's conscience and makes her restless at nights, but is aware of it all and tries to distract herself in household stuffs and learning new things. Patient has a fair insight what the cause of her problem is, and she has a fair insight, and she needs support to overcome the regrets and manage the follow in her life. So this is the problem what we understood of the patient as a individual R. So resolving the problem for the physical complaint. So we need to understand if this thing is happening actively while taking the interview. So we can give resolutions to the problems during the interview itself. But if we are not aware of if we are unable to evaluate the problems of the patient of both physical and emotional level, we will not be able to give resolution during the interview. So for resolution, for physical complaints, I advise the patient to try warm and cold application to the painful areas, so that the patient gets temporary relief, and also to obtain more modalities to be more specific. And for investigations, I asked her to get a CBC done, vitamin D3, B12, and uric acid. Because earlier she had increase in uric acid when she had allopathic treatment for her leg pains. So I wanted to see whether even now she had raised uric acid. And for personal sphere, no resolution was given to the patient regarding personal sphere. Later, what I realized that as a physician, I assumed that patient is doing whatever is possible in her control. So I got that impression during the interview. So I didn't give any resolution, but I could have suggested her to join some NGO, or I could have asked her if she was interested in religious activities, so she can spend more time, meeting new people, and that would distract her and give more perspective to life. Okay, so she could involve in then or join some online classes or online groups. Then knowledge of physician, what all were used. Physician had fair knowledge in general about the Indian household, so it was easier to build a rapport. And for specific physical complaints, more knowledge was required to reach to a definite diagnosis. Didn't explore behavior of in-laws towards patient due to no children of her own, didn't explore the reason for divorce of her husband's first marriage. So these were the spheres which the physician had missed. And sensitivity of physician was able to empathize to the most of the sphere. And in the entire interview only I felt that the physician got sensitized by the fact that the patient got married to an older divorced man, okay, which led to less exploration in that area initially. Okay, so because of that sensitivity, I couldn't explore that area initially. But now to what do you say, balance out the sensitivity, we need sensibility. Okay, so until unless we know what our sensitivities are, until unless we are aware of our prejudices, we cannot be unprejudiced. So here comes the sensitivity. When physician got sensitized by anything, she moved further and then got back to that area again. Okay, so the good sensibility, that is one point. And another one is she didn't judge her for regretting having no kids, because everyone have their own subjectivities. So I may be of that thought that it is not necessary to have kids, but I do not judge the patient for feeling bad for it or having regrets for it. Technical skills, what we have seen. So questioning, exploring, listening, and guiding were used most frequently. And occasionally silence and empathizing were used when the patient got emotional and she cried. And patient required more blocking and guiding frequently. But since physician had to formulate questions in her head, patient was not blocked as much as she was needed. So when I left some areas and I thought I would ask again, so when she was giving me irrelevant information, I was just hearing it, not listening to it, because I was forming questions in my head what to ask next. Okay, so sometimes, so in that way, the as much as the patient needed blocking because she was not answering to the questions rightly. I asked something and she was, she was just beating around the bush, or she had to be guided. Okay, I asked this. So what is about this? So she was not frequently blocked. So what the blocks of the physicians were? Physician, block of the physician. Patient was an acquaintance. Okay, the physician already knew the patient before she was a patient. So, and the age gap, and the existing relation that I already knew the patient, it blocked me to ask questions regarding sexual sphere. So I didn't touch that sphere at all. Then physician totally accepted the world of the patient and assumed it to be optimum. So couldn't suggest any resolution for personal sphere of the patient. So here what the physician has done is just took whatever the patient was giving. So judgment of the physician. Physician was able to receive patient empathetically without getting fixed. Judgment regarding the investigation was also fair enough. Doctor-patient relationship. During exploring the physical complaints, there was very formal relationship of doctor and patient. Then during exploration of obstetric history, more empathy was expressed. During life space exploration, there was a friendly relationship as patient herself talked about her college days. She was comfortable enough to talk about it, and not having any affair, and how her friend's mother broke their relationship. So she was able to express that. Okay, so this is an layout of clinical session evaluation form which we used to fill during our MD. So at Dr. M.L. Dhavle's institute, there is a process called ICR. Okay, so there is a course called ICR. during which they train the physician to become an unprejudiced observer. So this is the one of the form which we used to fill after every interview. So first we used to give the patient a history evaluation form. We used to get that history evaluation form written by the patient, so that we could understand what all areas we need to cover, what could be the probable cause of the patient's problem. So after that, we would plan our interview. Okay, after the it had another form to fill, which would we would what do you say define the problem, and we would resolve the problem, and what we would do in the interview to uh, you know uh, uh, to handle that. So this is history evaluation form, and I have evaluated myself under these headings. You can see doctor patient relationship, knowledge, sensitivity, and special recommendation. This form is for observer, because as in during our MD we used to, I would take a case, I would be a primary physician, and another physician would accompany me. They could be, my senior or my junior or my batchmate, and they would become an observer. Okay, so their part was just to sit and observe what the physician is doing, asking how the physician is asking the questions, and how the patient is responding to them. And the observer would fill this form for the physician for the betterment. So this was a very useful activity which we used to go through in our MD. And the objectives of this interview evaluation is to keep the track of dynamics during the interview, because we are not aware of it. As I said that we use these techniques pretty often, but we are not aware that we are using them. So to keep the track of dynamics, when we used, which technique we used with the patient, but what was required, where we went wrong. So until unless we understand that, it is hard to improvise on ourselves. Then to understand our own sensitivities and blocks, because we are also a human, we have gone through our different experience in lives. So to understand our own sensitivity, so that we can improvise on them, to keep aside our subjectivities as a individual, and to be more objective, to see a world from a third perspective, and keep our sensitivities aside, keep our subjectivities aside, and to become more neutral. Okay, so to become capable of understanding different worlds and perspective of patients, and move towards becoming an unprejudiced observer. So this is the objective of interview evaluation. And I'm not very sure how many of us go through that. So even before my MD, I don't remember I had ever reflected back on my interviews or the case taking where I missed what I missed, except if somebody have asked, you have not taken the modalities. Okay, I forgot to take the modalities. So that was a very what do you say, superficial thing. Okay, we do miss something. I most of the times I miss the habits of the patients. I forget to ask them whether they drink or smoke. So that is very superficial thing, but this is a very dynamic thing, because we understand ourselves and we become the unprejudiced observer, which Dr. Henneman has urged us to become. So this is all. I think it was helpful.
Thank you. Thank you so much, Doctor. It was really eye-opener.
Thank you so much.
Taking the case in a proper way and asking the questions in the way how the patient to the patient, if and even not expressing the real feeling, and even though not acting, really nice. Actually, most of these kind of feedbacks coming from the experienced hands, and I'm really appreciating you people, the juniors with much knowledge and more experience you are sharing than the experienced people. Doctors, very nice presentation and very great knowledge and eye-opener. Thank you so much. And we have hand raised. Who raised hand? I have. I have seen one hand raise here. Okay, anyway, those who have questions, you can ask to Dr. Yamini. She's really she have a bag of knowledge with her, so you can have it. Please ask questions and get it from her, please. Who's
Okay, so I remember the name of the web series I was talking about. It is Adolescence. I don't know if anyone of you all have seen it. I would really suggest all the doctors to watch this web series. I
where
think
it is, doctor? Where it is?
Netflix.
In the
Netflix.
Netflix. So okay.
Adolescence. So it is about a teenage murderer and how the psychologist, takes his interview and his psychology. So it is very wonderful to understand the world of a teenage, because when we grow up, we forget
You
what
are
we have.
you were first talking about this series, right?
Yes,
Okay,
yes.
okay, okay.
So
What is the name of that? Once again,
Adolescence.
Adolescence. Only adolescence. Okay.
Yes.
Okay, thank you, doctor, so much. And Dr. Indranil, please.
Yeah. Only small query, Dr. Yamini. You had done a good presentation. We appreciate it. Can you give some guidelines for acute case taking where a physician should not be a unprejudiced observer? Can you give some guidelines for them in short?
Yes, sure. I think during an acute, if it is more of a physical kind, questioning is what leads to the data what we need. Okay, so it is more of facts when we are dealing with an acute case. So as Dr. Boni Hussain has given, the locality, the sensation, modality, and concomitants, those are the most important ones. And mentals can be treated as concomitants. Like there can be a change in mental state. So we do not have to go into the the disposition of the patient. So we don't have to go in detail about what the patient's past experiences are. So we just need to have a current knowledge of what changes in the mind is occurring. So that is expressed through symptoms. There could be some mental symptoms, there could be behavior, and also some symptoms of intellect. So the evaluation of symptoms we have learned according to Dr. Henneman and Dr. Boni Hussain. So in acute cases, that is the most important thing.
Yeah, like you mentioned that you forget to ask the habits of the patient, but in acutes, if we miss to ask the habits, will it affect the case?
It can. If a patient is coming with the alcoholic fatty liver disease symptoms, and if I miss asking the habit, then I'll be just beating around the bush and thinking what is going on with the patient.
Acha, so we should follow the proform of case taking.
Yes, definitely.
Sure. It was a good explanation. No problem, doctor. Yeah, thank you.
Thank you, Dr. Indranil. And I'm inviting Dr. Ram Parvesha for giving out of thanks to Dr. Yamini.
Thank you, Dr. Anjani, and congratulations, Dr. Yamini Vashishtht. Very nice, excellent session. Describe the journey towards the produce observer. Very good selection topic.
I think I have done
two
two things. Either I have given a very good and excellent presentation that people do not have any doubt, or I have confused all of them. So I'm not sure what I have done.
Excellent session. Knowledgeable session.
Dr. Yamini, can you please close the screen share?
Yeah.
Yes, sure.
On behalf of IFPH, whole team, very, very thanks, Dr. Yamini. Thank you.
Thank you so much, sir. Thank you, everyone.
And thank you, Dr. Yamini. Now it is the time for the Malayalam session. And more than thanks, I'm appreciating you from the bottom of my heart. Really wonderful presentation. And I'm expecting more from your side. Bless you. Thank you so much. And we are moving to the Malayalam session and inviting. Thank you all those who are being with us. And now we are
Mm.
moving to Malayalam session. Bye bye, good night. And Dr. Mariamma John, you are welcome.